Okay, what time is it? Well, we'll give people one more minute before starting our brown bag seminar today. Okay, Amanda, I think we will get started if that's okay with you. Hi, everyone. My name, for those of you who don't know me, my name is Anna Langer, and I'm a professor of the practice of public health in the Global Health and Population Department. I also lead a program called the Women and Health Initiative that started a collaboration with the Harvard Global Health Institute 3 years ago. And well, we developed together the LEAD Fellowship, and we are now hosting the third cohort. We are very proud of this program, and our speaker today is a member of the current cohort. And it's my pleasure and my honor to introduce you to Preethi John. Preethi is a PhD specialized in health and development management with 25 years of experience in public and private sector organizations. Her expertise and experience have groomed her as a leader and institution builder in India, and she has worked also globally in other developing regions. At Chikara University in Punjab, India, she got the opportunity to pilot a model for the development of allied health professionals and established the Chikara School of Health Sciences as its founder dean. She is currently the director of the Chikara Global Health Institute, and she also serves as advisory board member to health and development NGOs. And she is the co-founder of the Women in Global Health India chapter. Preethi is currently, as I said before, a 2021 LEAD Fellow, and the title of her presentation you can see on the cover slide. So Preethi, it's a pleasure to have you with us today. The floor is yours.
Thank you very much. So at the outset, I feel extremely proud to be here and present in today's Brown Bag seminar. And I would like to really thank at the onset Harvard School of Public Health for this opportunity. The title of my presentation is Human Resources in Healthcare, a vital link for achieving UHC, Universal Health Coverage, from an Indian health system perspective. The outline of my presentation is very much what Dr. Langer, when she introduced me, she talked about a pilot model that I had done at Chikara. So this entire presentation is to focus on the allied health professionals and talk about an innovative model to address the challenge of lack of allied health professionals. So to start, I thought I will take an example from neonatal mortality, a huge concern everywhere, including in India. In India, it ranges from a very high of about 35 to a low of 6. So I thought I would begin with just posing a question, as in clinically, all the different teams are aware of what are the causative factors of neonatal mortality. They're also aware about the different treatment modalities. And yet we see that there is this huge variation in India for addressing this challenge. So my opening question is, what could be the reason? Now, when we think about the answer to that particular question, if we ask in India to anybody, whether it is the layperson or even in the healthcare team, as what constitutes the human resources in healthcare, people would talk about the doctors, the nurses, midwives, and probably the frontline health workers. But many other professionals, which belong to more than 50 different allied and healthcare professions, they remain underutilized and unregulated in the health system. So for example, in the case of that neonatal mortality, the multidisciplinary team would require respiratory specialists, would require lab technician, radiographers, besides counselors, dietitians. So this is a category that I am going to be talking about. So in India, the allied health professionals refer to the group other than doctors, nurses, and midwives, pharmacy, as well as the frontline health workers. So who is the allied health professional? So it's been defined broadly as this 50 or 60 different groups. And if you see, it's actually the people who do the diagnostics for us, like the lab technician, the phlebotomist, the radiology, the people who take our X-ray or help us with our MRIs, the people who provide treatment, like the dialysis therapy technologist or the burn care technologist, inside the operating room assistants, the people who do community care, like health educators and promoters, or the people who look after rehabilitation work, like physiotherapists, occupational therapists, and other rehabilitation professionals. Now, there is enough evidence which has connected the role or the critical role of human resources in healthcare to the universal health coverage. And this is just one example of an article which came out in World Health Bulletin several years back. Now, when we consider India, for most of the diseases or the health problems that we have, clinical competency of the health professionals which are there is adequate. And one of the evidence to quote the competency adequacy is the fact that, well, they migrate to developed countries and they seem to, they seem to be okay there, which means that the basic training must be pretty okay. The other thinking is, for most of the needs to provide healthcare, like infrastructure, medicine, consumables, equipments, and instruments, we kind of have it. And with money, if money was available, literally everything can be sourced overnight. And India is also a large producer of all this, as during the COVID vaccination time also we saw that. But let's reflect. Even though all of these resources on the previous slide could be kind of literally arranged overnight if money was available, can human resources in healthcare be made available similarly? What is the minimum time period which is required to develop a competent human resource? So on one side, there seems to be a time that is required to develop healthcare human resources. On another side, we are really witnessing an accelerated pace of development among the medical industry. I've just named a few, but there are many more, whether it's Medtronics, whether it is Siemens, GE, Philips, just to give an example of a few which are really producing a lot of technology. Now, the question is, for the technology development which is taking place, the medical technology development which is taking place, are there human resources being developed commensurate with the development that is happening in the industry? And whose responsibility is it to produce human resources for healthcare? In India, even though healthcare is the responsibility of the state, it is a state subject, it is academia, as in countries all over the world, which are responsible for certifying the human resources in healthcare. And at this point, I am not talking about a certificate course. I'm talking about degree programs offered by universities. In India, there are about 1 million physicians. We say allopathic physicians. Now, in an ideal scenario, we should have 10 times more allied health professionals for an efficient and effective health system. Today, India just has 1/3. So what was happening? I mean, before the allied health workforce came into the scenario, or even there is this shortage, how is it getting addressed? Well, traditionally, it was nurses who bore the brunt of any extra role. So as new technology came in, it was nurses which were asked to look after it. But the pace of technology getting into the health system was so high, it was necessary to have a separate set of different cadres. The allied health professionals was required. This is a WHO report which talks about 4 dimensions to look at HRH. It talks about availability, accessibility, acceptability, and quality. That is, not only should there be sufficient numbers, there needs to be available in sufficient mix across the different geographic regions, so that the patients for whom, or the community for whom these healthcare professionals are to serve, it's accessible to them, whether it's through, in terms of their timing, in terms of the transportation required to reach it, in terms of disability-friendly infrastructure. The people, the human resources need to provide care in a manner that recognizes the dignity and the patient centricity that is required. And yet it must be delivered with high competence and ensure less medical errors, high patient safety, etc., to ensure high quality. Now, in this report, what they did is they looked at every country and they tried to map on all these 4 parameters where the country stands. And this is how India stood. And I basically, there is a lot of numbers, and I basically want you to look just at this down part where I have circled. This report, when it looked at availability, accessibility, acceptability, and quality, they looked only at dentists, midwives, nurses, pharmacists, and physicians. The allied health professionals were not even in the picture. And I just want to raise that single point that when they tried to do this report, they would not have got the numbers they wanted to get what is the total number of allied health professionals in the country. Because this group of people, it does not come under a council. So as far as India is concerned, the Indian constitution is concerned, it's not recognized, this profession. So it doesn't even get reflected. And during, if I speak about during the COVID time, there were so many newspaper articles which talked about the doctors, the nurses, the frontline health workers, but the amount of media coverage or the research which was there on allied health professions was negligible. This is data which came out of a study in 2018. And again, I want you to just look at this last bit where the numbers are all either 0 point or 1 point. Now, ideally, we would like 10 allied health professionals for every doctor. And the numbers, and I've just shown a few states. So this is appallingly low. So one, the data is not available. And with that minimum data, they're hardly enough, that too in the skill mix that is required. So currently what we are seeing is, if I could put all the people into a triangle, what is seen is the allied health professionals are the lowest in numbers. Then comes the doctors. And the base of the pyramid are the nurses, and we can include the nurse and midwives. This is how it is currently. But ideally, we really would need the allied health professionals to be at the base of the pyramid, then the nurses, and then the doctors. This is considered an effective health system. Now, I would like to go into a case study of the human resource healthcare at the Aravind Eye Care System. Now, Aravind Eye Care System, it actually came into limelight with the Harvard case study on its model. And one of the key findings at that time and over the years has been the fact that the efficiency of the Aravind model revolves around the allied health workforce they have. Now, here is one organization which provides healthcare where there is approximately 60% of the total number of human resources being the allied health professionals. So they have managed to reach that optimum ratio. Now I'd like to move on to what is the model we piloted at Chitkara. So considering that there is a need for increasing the number of allied health workforce and actually being part of a system wherein a healthcare delivery, it was a proven model that if we increase the number of allied health professionals in the right mix, better healthcare can be provided. At the same time, there was this report which said that there is about 7 million allied health professionals, which is the shortage. Now, this is really huge. There is only 3 million. If the country needs 10 million, currently only 3 million are available. This is a report which took, I would say, almost 2 decades of work to finally see light. 2011, this report came out, 2012. And one of the key things, as the title itself says, so this is a newspaper article based on this report. Now, the report is titled From Paramedics to Allied Health Professionals. This was the first report which did an in-depth study in India to understand what is the scenario of allied health professionals. And the very first part was even acknowledging there was no single terminology which kind of addressed this entire group. So there were so many different terminologies, but the most common being paramedics. And many of the allied health professionals, they were of the opinion that paramedics somehow devalued them. And this stakeholder study felt allied health professionals, which was the blanket term for this 50 to 60 groups, was fine. And this study showed that it highlighted the different groups, the roles, and particularly the shortages, as well as where the shortages are. So at the time of this report coming, at the Aravind work happening, what was kind of clear by this time is the allied health workforce, there was a huge shortage, particularly in North India. So if we look at where are the allied health professionals, they were definitely much more in South India, skewed to other parts, but North India, there was a definite shortage. There was no standardized curriculum or a council. And traditionally, they were getting educated in public medical universities and private. Now, the problem is in the public medical universities, the number of students that they would take under the allied health professionals cadre was an extremely low number, very often just 1 digit and sometimes 2 digit, with a very stringent entrance criteria. So if the strength was, if the intake was, let's say 4 students, if the students did not meet whatever criteria they had, they would just let the seats be. So public medical universities, there was a problem. They were not catering neither to their own needs nor to the needs of the surrounding areas. Private medical universities had no preference for training allied health professionals, because from the leadership or the promoter's point of view, the fees for this group did not incentivize them to offer these courses in comparison to physician education. So most of the physician education was preferred in private medical universities, though of course to meet their own requirements, they did have other courses. But again, numbers were not really catering to provide for the state or the other places. At the same time, good quality private non-medical universities, they were abundant across India. The idea was, can we look at them as an opportunity for training allied health professionals? So on one side, Chitkara University, it is a university which is started by academicians, which has a very good reputation. And they were already running several schools with good management. But a hospital environment was not there where the practical and clinical training could take place. So the idea was, could there be an academia industry collaborative educational program for developing the AHPs? Local hospitals with good patient footfall was negotiated to be the collaborating partner where the students could go for their clinical training or internship after completing their preclinical training and practicals within the campus. Now, result of this pilot. So we started with just 2 programs. A degree program were lab technicians and imaging technicians with about 30 intake. By 2020, we had 10 programs for allied health professionals with a total student strength of 2,000. And what was very interesting for us was when the students were graduating, they were able to get jobs both in the private sector and in the public sector across different states of India. Very soon, so from 2011 we started, so I would say within 5 years, there were several other universities in this region which had replicated this exact same model for training allied health professionals, realizing its importance, potential, and particularly the placement opportunities. For private universities, placements matter a lot. So here was this group where hospitals were just waiting. So before, in the 1990s, I mean earlier, prior to this, how were the hospitals managing? They were having diploma level students or they were actually going to other places in India and doing recruitment and bringing them to work in these hospitals. Competency-based curriculum helped to groom the highly skilled workforce. And this actually was very visible in our placement, because we literally had people, asking for students, and we just never had enough for what was the demand out there. These are some snapshots of the different training that we offered. So this is operation room technicians training, the imaging technicians, dialysis technicians, medical lab technicians, occupational therapy, physiotherapy, optometry. So these are some of our students in their in the university campus, in the practicals, in the classrooms, etc. So during this journey, my analysis is that a proactive partnership approach from the corporate medical product companies to accelerate the development of the AHPs by the academia would be ideal for their development. Currently, there is a big mismatch between the medical industry growth versus the academic training of AHPs and overall people's interest in educating the AHPs. Corporate venturing could be a way to address this huge unmet need. A revised national education policy in India came out last year. And one of the recommendations has been a very strong industria-academia collaboration. Now, corporate venturing, just to discuss a little more about it, the context is, most of the Indian private university, and I'm talking particularly about the non-medical private universities, the leadership are either from a business or a background which is not related to healthcare. So their understanding, knowledge, or experience of healthcare, or the need for the diverse set of allied health professionals, the skill mix, is not much there. So it is a constant challenge to advocate and create that awareness. And this can be fast-tracked with corporate intervention. This can be a win-win situation for the industry and the academia, ultimately benefiting the health system. The other learning that during this journey was, we had slightly more girls, out of the 2,000 students. So we probably had 1.5 girls for every boy. So there were more girls getting admitted into our courses. But when we were looking at placements, initially, girls were not joining these careers. It was more, they were getting the education, but not taking up a career. So as soon as we understood this challenge, we really started doing a lot of different activities. Literally from semester 1, we started career counseling, placement opportunities, a lot of industry guest lectures, field visit to expose them to different organizations, a lot of symposiums, conferences. Just a few, again, pictures of the different activities we tried. So that helped on one side. And the other side, March 28th, 2021, this year, just a few months back, was a very momentous point for Indian allied health professionals' journey, because the National Commission for Allied and Healthcare Professions Act 2021 was finally passed after going through so many changes. I think over the last, literally for the last 6 years, 7 years, we were wondering whether it would make it, but finally it made it through the parliament this year, and this is quite historic. Now, what this commission, National Commission for Allied and Healthcare Professions Act 2021 talks about is, and just a side note, a little bit of the story. You can see the word is not allied healthcare professions, it's allied and. So there was a lot of lobbying because the physiotherapists, maybe the optometrists, they all felt, well, we are not under the allied health. We are a distinct group by itself. So finally, everybody agreed to this term, Allied and Healthcare Professions Act. And it covers this range of courses of medical laboratory and life sciences, trauma, burn care, surgical anesthesia related technology, physiotherapy professionals, nutrition science professionals, ophthalmic science professionals, occupation therapy professionals, community care, behavioral health sciences, and others. And you can see, when I saw this, I felt like a lot of things were just lumped under this because mental health and similar fields are still not developed. Medical radiology, etc., medical technology, physician associate, health information management, and health informatic professionals. So out of these 10, by the time the act came through, we were able to offer 7 of these. And actually, I talked about initially about 50 different cadres. So that 50 has been divided under these 10 councils. Now, what is the function of this commission? So one is we have a commission to frame policies. The other very important thing is to maintain numbers. So we would like to know an updated live registry of how many allied health professionals are there in the different specialization. And also it completely standardizes the education, the curriculum, the faculty requirement, the qualifications, etc., as well as a unified or a standardized entrance and exit examination. So in short, this really served to address the entry challenges that the idea being now this policy has been passed at the national level. With health being a state subject, it is the responsibility of the state now to implement it. But the idea is that we could address a lot of the current issues if this goes ahead. So national standardization of exit competencies. This is another huge advantage, as well as lifelong certifications. The other is having a human resource information system with registration. The other is a recognition of the challenge of career dropouts. And there's been more research on this. And it's particularly found women allied health professionals retention is a challenge. So there is this general statistics which talks about 75% of healthcare workforce at entry level are women, and 25 years later, the leaders of healthcare are men. Now, this equally applies to the allied health professionals as well. And that's one of the reasons that I got interested and became part of the Women in Global Health movement and set up the India chapter. Because the whole idea is, what can we do for the allied and health professionals among other groups to amplify the voices, to prevent women from dropping out from careers, to address these issues, and particularly look at career progressions as well. So we've tried webinars, we've tried a lot of writings. In summary, in conclusion, competent AHPs with the diversity that is required are the backbone to an effective health system. It is necessary for a country like India to really look at the synergy that industry academia partnership can offer. corporate venturing for scaling up AHP's training and development, could be in the form of setting up training or simulation labs, advocacy with the university leadership, again, advocating for ensuring very good clinical training. So on one hand, we are looking at how do we scale up the numbers, because that's one huge challenge. But equally big challenge is how do we ensure the people who have gone into the healthcare, allied health professionals system, how do we ensure they're motivated and they are retained and they do not drop out early? And particularly, what can we do if retention of women is such a huge issue? What can be done to address that? And at the same time, it is recognized that the blessings of a proactive state government in terms of regulation, standardization, policy framework is absolutely necessary. And all of this, in turn, would lead to an ideal framework of AHP workforce creation and development. I conclude with the message that WHO has declared this year as Year of the Health and Care Workers in 2021. So it is not only enough that we look at different ways to increase their numbers, ensure that they are there, ensure that they are providing quality services, etc. But we also need to recognize and appreciate them, and they need to become far more visible. With that, thank you.
Thank you so much for a wonderful presentation that highlights dimensions of the health system that we definitely don't think enough about. This is a great this was a great presentation. Thank you again. Now the floor is open for questions, comments. I think, Amanda, that now you can take the slide off so we can see people who raise their hands. Tom.
Yes, Preethi, I want to thank you very much for a wonderful presentation, very important issue. I don't know if you know this, that our program has a course on human resources that I think we'll be having in June, and I hope we can invite you to give a presentation in that course. It's an executive course and a lot of people that would be very interested in it. I guess I have a question about one of the key problems about nurses and allied health workers is how they are accepted or not accepted by the public and by the other professionals, right? Especially and the kind of things you're saying about allied health workers, the nurses will also complain that they have the same kind of problems, but often they're caught in the middle and they are not terrifically happy about getting more allied health workers who might be doing some of the tasks that they're doing. So I wonder how you address, or whether you've done any studies to find the acceptability and the interest. I mean, I'm sure that the corporate sides can see an interest in hiring allied health workers because of they're likely to be less expensive and maybe even more productive. But the other allied health workers and the patients may be part of the problem of getting them and maybe contributing to the lack of retention of the people that you're talking about. So I'm just introduce that as a topic to consider.
Okay. So first, thank you for the opportunity. Second, in terms of addressing, I think, the range of questions that you have raised, nursing, at least from a university perspective, is very established. There is a nursing council, and while there still isn't enough nurses in the country, nurses or midwife. And of course, there are other challenges like migration, etc. The fact is, nurses are very recognized by the community or the patient. So, if you ask who is providing the care, they would talk about the nurse. Or, even if you're talking about a specialty, I started off with the example of the neonatal unit. So if you go to a NICU, they would talk about the specialized infection control nurse, etc. But one of the big challenge, the way I see it, is education is in silos. So a student who decides, they would have all studied together. But then if somebody decides to be a physician, or somebody decides to be a nurse, or somebody decides to be an allied health professional, during the time of their education, they never literally speak to each other. And this is one thing I tried to address, at least because we also have nursing, we have healthcare management in the university. So we try to offer courses like, for example, patient safety, where we try to promote a team training approach so that at least they will learn and respect each other. So I think that's an important step to health professionals respecting each other, that they also get educated together, both in the university as well as in refresher training. Because when they take up jobs or they go finally to the hospital, there is definitely a lot of teamwork that happens there, but they're not trained for it. In terms of acceptability of this group, the services that they provide are so important. For example, during the COVID time in the ICU, people talked about physiotherapists who were in the ICU managing the patients. So for those hospitals or the ICUs which had that luxury of the physiotherapist, or let's say it really helped. Or you look at rehabilitation, the work is so important. And so one of the things we saw, I talked about a webinar that was done with the allied health professionals. So one of the points that was shared was many of the services got disrupted during COVID, like, for example, counseling, taking care of a disabled child, etc. And it was all provided by the allied health professionals. So I think for the group of community that takes their services, they realize the need. But is there a broader awareness? That there isn't. That will need to be changed. Is there an issue about, will my job get taken by the other group? Like, for example, nursing is providing a particular care. Now the allied health professional comes in. I think the mix has been the nurses focus on patient care, and wherever the allied health professionals have come in, where the nurses are there, it's particularly to do with technology. So I think there's been within the hospital or the team, that issue is not there. And anyway, the numbers are not high to have reached a saturation or any conflict. At this point, the worry is more for a radiography professional is, will artificial intelligence tomorrow increase to an extent, which is like, that's like, at least for us, that's like years away still. So, yeah.
Thank you so much. Stephen?
Thank you very much, Dr. John. That was a brilliant presentation. I thought you clearly laid out the need for enhanced education and the evolution and the role of your 10-year project on developing this form of training. And you pointed out the difficulties in maintaining women in the profession. There's another point that was hinted at, and that is in the National Education Plan, as you mentioned, which is the role of industry. And obviously in a field like this, where the new developments are the products of industry, and therefore people being trained in these professions need to use them. But my question is one that I assume that you've addressed, and I'm curious to know how, is conflict of interest. Have there been any potential or actual conflicts of interest that arise between the people that you're training, as you said, in academia, where you have standards, and the industry, which has its motivations? So there can be conflicts of interest. Has that been raised, and how do you address it?
Well, I think wherever corporate is there, that will definitely be an issue, as you rightly pointed out. I think the conflict of interest comes because the corporate would like the people to be trained in the shortest time possible. So when we look at graduate education, we think it is a holistic development of the student. So they need to be good in communication. They need to be good in using computers, just as an example. Now, for a corporate, they would think, why is it necessary to improve communication skills? Why can't we get rid of all these parts of the syllabus to reduce the time to focus on what is their need, which means it's not a well-rounded graduate that comes out. It is only tailored to their interest. So at the university, having a board of studies and keeping the control over the curriculum, and now that we have a national curriculum, which again has been put together looking at what is India's needs, also what is a global curriculum. And this particular policy, it has been mapped to the international occupational standards, so that if a person does the minimum education, they can be useful in other places. So there is a conflict of interest, one I would see in terms of change of curriculum. Second, how much time should the students spend in the university versus in the clinical training? Because there is an optimum balance. And what is that optimum balance? University would tend to think that we are producing a graduate student to be a citizen of the country, whereas their interest is, give us somebody like really fast who just needs to know this. And if it is a very high technology industry, they feel that the basic, for example, for a lab technician, there are manual methods of doing it, which is sometimes required when you are going and working in a rural area or in the primary healthcare system. So we cannot override that just to teach to a tertiary care setup. So I think, I would think the biggest conflict has been in these areas.
Oh, sorry, I was muted. Thank you so much for that response. Any other questions or comments for Preethi about any aspect of the subject she covered? I have one question, if you don't mind, about about women's dropout of the healthcare workforce. That is obviously an issue everywhere, and not only in India, as you pointed out. You mentioned many things that you are doing to retain girls and women to the extent possible. But what would you recommend what would you think needs to happen at the societal level to make the retention of women in the health workforce more feasible? Because obviously that has to do with the expectations, the gender expectations, and the way that roles within the family are distributed, that will also influence the fact that young women study, but then they are not able to practice later in their lives. Is there anything that you think we could do as a global health community?
So one is, I just think the students or these allied health professionals, they don't really know their career paths. So nor do they know of options which are possible. So for example, even if you can't do a full-time work, there are other options, but very often people don't know the options. We did a panel discussion and we asked the students a simple question like, do you know any grandmother who works? Do you know any mother who works? So majority of them definitely, at least of the groups which I had seen, the grandmother was a definite no. I have not seen like a grandmother working like in leadership position or the mother, maybe it's more traditional jobs. So we were able to do something to change immediately after finishing the course, taking up the job. But now when I look at, okay, after 5 years of them working, what is happening? I'm seeing a dropout from my alumni. And again, when I'm looking into why are you dropping out, it's never because of reasons of incompetence. It's always because of other priorities. Salaries are a challenge. And I just think also that they do not know enough about working, about careers, and how do you navigate the system, career progression. So I think there's a greater need for awareness. And the other point is when they are faced with a challenge, like for example, maybe due to childcare, if they are talking with people who have not worked, the only response they would say is, yes, please drop out, because that's the solution they know. But if they talk with other working women who have traversed that journey, maybe they could find other options. And that's something I really see Women in Global Health trying to make that difference by enlarging the scope of possibilities of being able to continue in the career, but also go upward in terms of a career progression as well.
Thank you. Thank you very much. Alok?
Yeah. Hi, Preethi. So thank you. It was very nice presentation and very needed one, allied health professionals. So I was just wondering, the Chitkara University, is it a academic university or do it has a medical college also? And I just want to know if it is the training, because these degrees are mainly clinical skills apart from academia. So how do you think the quality aspect can be taken care of?
Okay, thank you. So this is a private state university, which is a non-medical university. So there is no hospital. And in the beginning, we debated whether we should set up a hospital. And at that point, the feeling was that running a hospital it's a huge activity by itself. It cannot, like the university here is the focus, and we cannot look at a hospital as just a place for training, So we decided to go with the model of tying up with a local hospital. And it so happened that was a chain. It is a JCI accredited hospital. So it's internationally accredited. And they were having a serious problem with allied health professionals. They were not having enough. Accreditation standards mandated that they use only certified, which means degree holders and not a diploma or a certificate trained person. Now, the important question that you asked is, how do we train when we don't have the hospital? So the way it works is, in the first year, we start practicals on the campus. So the group in the campus, we start with community work in the beginning. There are 5 villages around the university, which is adopted by the university. So we start with health checkups over there, which the senior students actually are a part of it, along with the faculty. The first year students go as observers, and maybe they will help in patient escorting or just seeing what's happening. So they're having exposure to practicals. They start going to the community. And then we start in the second year, we start with field visits. So they get to visit other healthcare, which is in the government side, primary, secondary, tertiary level. We take them to non-governmental healthcare systems. We take them to private healthcare systems. We take them to equipment, just different organizations. So they get a feel of the different. And then we start the preclinical training in the campus. And at this point last year, we were also able to set up a simulation lab. So we are trying to build up that resource in the campus. Now, how do we ensure their competence? Because finally, no matter what we do, since it is a healthcare professional, competence cannot be cannot be neglected. We used to say, a student can get a C grade, a B grade, A grade, and all of them are pass. But frankly speaking, if you were the patient, would you, if you knew this is the grade of the person who's looking after you, and this is a C grade person and this is an A grade, would you be happy? So what we said is competencies, the minimum competencies which are required are non-negotiable. So which means that they have to demonstrate that they have reached that minimum level before they can complete their internship. So we have a system for doing that. So one, we believe the training is good because of the good demand in our in terms of placement. We see people coming again and again, and other institutes coming. That's one. Second is, for example, for one of our allied health professionals, that is the optometry group, we actually got an Erasmus project. We have a couple of Erasmus projects, which are large multi-centric studies with Europe. This was with Europe, Israel, and India across different universities. So there is something called the European Council of Optometry and Optics, which is considered quite like a gold standard for optometry training. So they actually came and looked at our training, looked at our students, and looked at how we were. So we met the standards of ECU. And so, I mean, this is just one example along with placement. So I think we kind of do like a stepwise learning to take them from the campus to making them ready for their final internship, which is usually a year long in the hospital premises. Thank you.
Thank you. Thank you so much for your very comprehensive response to this last question. When our time is over, I thank you all for your interest, for your participation in this seminar, and big gratitude to Preethi for a wonderful presentation. Thank you so much, and we'll see you next Thursday. Look at those hands.